To welcome you all to the forum. I don't know if people can see me online. Can you see me online? Excellent. Ellis is nodding. My production assistant, quote, IT guru. So thank you, Ellis, for all your help. Ellis Hedges up in level 5. So welcome back to the forum, a new term, a very exciting program. We had Ramona Wojtek last week. Were you all here?
Yep.
Yeah, excellent. We were at the Cambridge Breast Conference, which Ramona was also speaking at, which was at Fitzwilliam College, which proves to be a good event. Welcome. So this week we've had a late program change. It's always good to keep us on our toes and keep our IT staff on our toes. But it's going to be neuro still, which is great. It was going to be Justin speaking about pediatric neuro cases, but he swapped with Tilak, who I'm reassured is going to also be speaking about neuro cases. Or not. So the great thing is Tilak was appointed a travelling professor with the British Society of Neuroradiologists, which is a great accolade. It really is. You have to be considered to be right up there amongst them. You do, come on. And because they want to have really good people travelling around the UK, inspiring trainees to go into neuroradiology, spreading good practice. So they only choose the best, and Tilak is absolutely one of the best. So we're so pleased that you did that. And Tilak has very kindly agreed to tell us about his travelling circus, professor tour. And we look forward to hearing about the good things, the bad things, and some of the feedback maybe that you got from other centres. Tilak, thank you so much.
Pleasure. Thank you very much. Thanks for inviting me. So yes, this will be about this traveling professorship, and what I'd like to do is tell you how it works, how it happened, and then what we talked about, and the feedback, as you say. But at the same time, if there's enough time, we'll keep it flexible. But I'll give you a taste of the kind of things that the lectures that we actually gave. And that also means that these were interactive at the time, and I'd like them to be interactive now. So it means if you have your phones and if you're online, you can use this QR code to access a page, which will then give you access to the polls. And the website will also be up as you do the questions. So there's not too many, it's just once in a while. But hopefully I've tried to choose the ones that I found most interesting and most fun to do. So I'm hoping that that you like it too. Great. And so there's nothing like having friends who don't do radiology to keep you down to earth. And so when I first told one of my very good friends about this traveling professorship, blah blah, I was very proud. I will. I was very proud about it. And a few months later, he asked me, "Oh, Tilak, how's the traveling circus going?" Like, well, actually, that's maybe not a bad name for it. Yeah, it is. It's slightly chaotic, quite fun. So, yeah, everyone ready? So, first of all, who was George de Boulay? He was after whom in whose memory this professorship is named. He was, one of the first professors of neuroradiology at Queen Square. Actually, it turns out he was not just a neuroradiologist, he was a veterinary radiologist. So he was the head radiologist at London, at Regent's Park, at the zoo, and where he studied subarachnoid hemorrhage and vasospasm, apparently. The other interesting thing was that when I don't know if Helen is on the line, but this is just a hint. When he got his job at Queen Square, apparently there were no offices for him, so he bought a garden shed and put it on a roof, and that's where it was for 20 years. So I thought that was pretty impressive.
Actually, we do have a roof space.
Well, there you go. So what's the aim of this traveling professorship? It's quite a few of the special interest groups, or specialist societies have these: musculoskeletal, breast, head and neck, and so on. And the aim really is to promote that radiology and that subspecialty amongst trainees in the UK. And for us, it was to raise the profile of neuroradiology, and also to raise the profile of a career in research in neuroradiology. But as Fiona mentioned earlier, one of the main things was to promote good practice, and so that's one of the things that we tried to do here, and I'll show you how. And the post is funded partly by the RCR, 50-50 by RCR, and in this case BSNR, British Society of Neuroradiologists. So how did it happen? So we're invited to apply. So recently there will be fresh appointments for the next professors, and it's a competitive interview which you can apply to as a joint, as two people doing a joint application or separately. And it just turned out that with BSNR, they had a joint application, I think about 10 years ago or so. And then since then, every set has been a pair of joint professors. And I think that's a really nice way of doing it, because not only are you sharing the work, but you're bouncing ideas of each other, and the trainees also get a variety of points of view. So we do the interview, we have to make a proposal about what we'd like to talk about. And then the Royal College will contact the training program directors and ask them who would like a professor to come, a traveling professor to come and visit. And then they'll respond. And then whoever responds, they're the ones that we then organize to go and see. So we can't just pick and choose, the warm bits of the UK that we want to go to. We choose whoever will have us, which is quite fun. And so we were appointed late in 2019. And of course, as you can guess, 3 days before we were supposed to go on our first visit, which would have been to Plymouth, the first lockdown was imposed. And so that was all cancelled. So we then had to reorganize ourselves, and we did our first few visits as online, virtual ones, as you might expect. And those were to London and Southampton. London, we did essentially 2 visits in one day, one in the morning, one in the afternoon. I think one was for north and one was for south of the river, effectively. So we had a lot of people online, but we realized then after those 2, it was quite tiring. And it just felt like doing a webinar. And at that stage, the BSNR had already started doing their weekly, educational webinars. And it was quite difficult to engage, 60 or 80 people online, as you might imagine. So our feeling was that actually we would really benefit from doing this face-to-face. And so we didn't do any for the rest of that year. We asked for a year's extension to our posts, and then waited until restrictions were lifted before we could start doing visits. So in the end, we did a few visits across the country, including Aberdeen, and then the following week straight to Plymouth, and then some bits in the Midlands. And most of those, now that we learned how to do online meetings, were hybrid meetings, so that trainees from around those areas could also join in. So for example, Norwich one, the Cambridge trainees were invited to join. So that meant that we could at least to some extent reach a much greater audience, which is great. So we had about, in total, we probably saw 200 trainees roughly. Does anyone recognize the top image? These are 2 of the visits that I really enjoyed, because I'd never been to these places before. So the top one is Norwich. And that's a big poster or big piece of art in their academy. And the bottom one, seashells. It's going to be another academy. Plymouth, exactly. That's very good. Well done. It's a peninsula. So I really like their sort of motifs, and those are fun. I'd never been to an academy before, so it's quite eye-opening. It was very interesting to see. And so what we did, so the other joint professor was Dr. Sam Mills. She's a neuroradiologist in Liverpool at the Walton Centre, which is a neuro centre. She has a very strong academic background, but now is mainly clinical. And what we decided to do was a theme of standardization. So that sounds kind of, okay, we're going to talk about standardization for, but because we might end up, hopefully we'll end up with apples all exactly the same, right? But standardization is quite interesting because we see it a lot now. We see it in all walks of life, of course. And to some people, it means, that could look beautiful, all those houses exactly the same, but in a very beautiful place. But to some people, it just means, you have to follow the rules and you don't have a choice. But for others, it means that it enables a lot of things. So, if we didn't have standardized measurements, if we didn't have the meter, then where would we be? If we didn't have the kilogram, then how would anything work? So that's the sort of extreme of it. And so we chose 4 core neuro topics: tumors, stroke, multiple sclerosis, and dementia, because each of those has some sort of guidelines or some attempt at standardization behind them. But they're all quite different, and I'll talk through that. And so that's what we wanted to explore. And this is not about just teaching or preaching, it's about encouraging a discussion and making, starting conversations about these things. Both of us have been involved in some way or the other in the past in developing NICE guidelines. And so we thought we'd bring that experience also to how do these NICE guidelines actually get developed? We take them in a way as gospel, but they're still only guidelines. And those 4 were aimed at trainees generally. And then we had a couple of other lectures, also standardization, but much more general, not neurospecific. And these were aimed at not just trainees, but other consultants in those centers were also invited to attend. And so we chose, Sam talked about standardization in the NHS. She mainly talked about standardizing imaging and protocols and so on. And I talked about one of my pet favorites, which is structured reporting. So just a little bit about each of these topics. Why did we choose them? So tumors, there's NICE guidelines for tumors. But what's actually quite interesting is, although there's a huge amount of evidence in oncology generally, especially in terms of treatment and so on, when you look at imaging specifically, and even looking at the NICE guidelines, it turns out that there's actually very little evidence on how you should image a tumor. So a lot of the guidelines are based on consensus. There are experts who were the NICE panel, the panel that were brought together for the NICE guidelines, and they decided, well, we always do a T1 without and then one with contrast. We do an axial T2, we do a flare. I think these are essential. We couldn't live without them, and so they're part of our tumor protocol. But the ones that have the most value, for example, is not actually that clear. So that was the first interesting point here. And the other one with tumors is surveillance. So once you've treated a tumor, when do you do the surveillance? Every 3 months, every 4 months, every 6 months, every 12 months. For meningiomas is different from, of course, GBMs and so on. And I think a lot of our practice is driven by clinical trials, and whatever the schedule that's happened in a clinical trial kind of gets transferred to clinical practice. But again, the evidence behind, should you really be doing it at interval, or do you need a higher interval, is not clear. And so those are some of the issues that we're talking about here in terms of standardization. And then on the other hand, stroke is very different. So there's been a revolution recently, of course, with thrombectomy. And that was based on really good, high quality, strong evidence. And so we talked about how good that kind of evidence has influenced the NICE guidelines and also our practice. So for example, in Cambridge, we used to do a lot of CT perfusion for strokes. And even at the time, there was a feeling that maybe we were doing a bit too much of CT perfusion, and we're becoming dependent on needing it to reassure referrers or patients or whoever that this was not a stroke, for example. Yet actually all you need for stroke at the moment anyway is a plain CT, is that bleed or not bleed, and then evidence of vessel occlusion, which is your angiogram. And so by using the NICE guidelines, we've gone back to that kind of protocol and using only CT perfusion now for those special cases like a wake-up stroke. You don't know what time they've had that stroke. Is it still worth treating, and so on, which is what the guidelines also suggest. So that evidence is strong, and that's been helpful for us. What's also quite interesting is with NICE panels, you wonder why, actually there is quite a lot of evidence. Why haven't you taken this into account? Why haven't you taken that into account? And they've got excellent, statisticians and researchers. They do a huge amount of research, but they will only consider really strong evidence. So if the evidence is not the highest quality, if it's not sort of 1A or that kind of level, then actually they say we can't consider this evidence. It's not good enough. And so that's why you end up with guidelines that may not actually fit what you think should be the practice. So again, another sort of issues we had conversations about. Now, of course, while we were doing all this, we also looked at cases. And so one of the things that we do as radiologists is try and spot the infarct on an unenhanced CT first, and we look at early ischemic signs, which I'm sure you've all heard about. So I wanted to kind of show what the evidence was, or how strong were these, how sensitive and specific were these early ischemic signs. So if you bring your phones out, your first question is this, and here's an example. Your phone should show you, if you might need to refresh the page, an image, and I'd like you to tap where you think the stroke is. Or even which side, I'll go with that.
Could you please show the QR code again?
Oh, sure. You can access that that web address. If that's okay.
Ellen just like, and I agree with, but like, hit the tail of the dog.
Yeah.
For us anyway.
Good, the results are coming in, very good. Hopefully those online have two devices to look at this from, or you can swap to a web page. Well, some people have taken the answers away. All right, shall we have a look? Yeah. Great. Well, the consensus is correct. So, you know, the majority have it in the left insula, which is the bit where you've lost some of that differentiation. You don't see that insular ribbon.
Helen and I are very pleased about that.
It's about the sign. Yep. All welcome. But it's quite interesting to see that it's actually not that easy. And I'll show you what the spread of responses was from the other centers. I haven't named any of these centers, but you can see that in some centers they did really, really well, and some were very, very mixed. Now that might reflect, you know, the range of trainees that we had in the audience, or it might just reflect the intrinsic difficulty of this task. And actually, these early ischemic signs are quite specific if you see them, but it's very insensitive. So you're looking at about 50% sensitivity. Okay. So then another topic we talked about was MS, and there are no nice guidelines about MS, or certainly not about imaging in multiple sclerosis, and yet it's a very important area. And of course, there are now many, many treatments. And so what Sam is an expert in this field, and what she was starting a discussion about was, where did all these guidelines come from? And it turns out that some are from consensus guidelines from big societies, but some are from industry. And, you know, are these guidelines, so she examined these guidelines, are these good enough? Are they appropriate for the United Kingdom? Because they've been designed in the US or in Europe, where the healthcare system is very different. And so we asked, you know, our groups what they thought of these ideas, and these are the word clouds that came out of those things. I won't ask you at the moment, but that's the sort of exercises we did. And yeah, a lot of people realized that, you know, North American guidelines might not work very well. They do a lot of contrast imaging, for example, that we don't think is always necessary. And some of those are sponsored by, you know, there are pharmaceuticals that make contrast agents that are involved in some of these guidelines. It's quite interesting. And then my topic was, another one of my topics was dementia. And so nice guidelines behind dementia are actually more related to, you know, PET scanning and all the PET agents and so on, and for the different types of neurodegenerative diseases. But we see it all the time. And so what I was trying to, and huge thanks to Dan Scoffins, is he used to do this excellent presentation on a practical approach to dementia. So I use that as the basis of mine. Because to show trainees what you can do even with with a CT scan in terms of understanding neurodegeneration and other causes of dementia like vascular dementia. So what are the definitions? And we talked about simple scoring systems, which anyone can apply, quite easy to apply, and actually turns out that clinically, at least at the moment, they're as good as doing quantitative analyses of high field MR. Because of the, I suppose the context we're in is one where you can do a lot of diagnosis, but not much treatment yet. And because of that, qualitative analysis works. So those scoring systems were a type of standardization. So I encourage the use of those, or at least understanding those so that you can understand how to describe different types of atrophy. And this is one of my favorite bits in that it's quite interesting, the variability, the subjectivity of scoring atrophy. But the scoring systems are fairly simple. So I did another exercise, which I'd like you to take part in, which is have a look at, this should be a movie, I'll play it. I'd like you to have a look at the brain, and then the question that will come up in the next slide, so it won't be ready yet, is how bad is the atrophy? So do you think it's mild, moderate, severe? Make a decision while you look, and then you'll be able to answer the question quickly. How old is the patient? History withheld. But they had a headache. Okay, so what do you think? No atrophy, mild, moderate, or severe? How would you grade this? Okay, everyone's decided. We've got 23 responses, pretty good. Let's have a look. Okay, so quite a spread. So it just shows, how difficult it is, and it's one of the things that we learn over time with experience of looking at lots of brains. So I wish I could find out who it was that called this severe. So this is my brain when I was when I was doing, and not just my brain now, which might be severe, but this is my brain when I was at the peak of my abilities during my neuro fellowship. So quite. But to be fair, when I first saw these images come out of the scan, I was taking part in it as a volunteer in an experiment, and I asked for the scan. Yeah, thanks a lot. Fair enough. With the history, it makes more sense. I did look at my brain and think, I think that's mild atrophy, at least. So yeah. But what was interesting here is there's some interesting studies. For example, one of 100 radiologists, a set of radiologists who were asked to look at 100 scans and score them, mild, moderate, severe. And then they were shown templates of mild, moderate, severe, and then they could use those templates to score the same scans again at some later interval. And they changed about 60% of the initial judgments. So that's the kind of thing, I suppose, where machine learning and things would help to make things more consistent. And then, so those were the four sort of core talks. And then we started talking about standardization within imaging and structured reporting. And so Sam her dad is an aeronautical engineer, and she used the way they standardized diagnostic techniques in aeronautical engineering and aerospace with similar. She compared that to imaging because they use ultrasound, they use X-rays, and all kinds of very similar sounding things, but obviously they have very, very strict standards and guidelines. So we don't really have those. And she had examples of how not standardizing the imaging, for example, this is a patient being followed up with meningioma, just made it much more difficult to compare, over time and so on. And this is my favorite question from her talk. So you can answer this as well. So the question is, standardization is the death of autonomy. Do you agree or disagree? You can just tap, it's an image, you can just tap on the answer that you would go with. Remember, it's all anonymous. Oh, great, 30, very good. All right, so that's weird. Were they all removing their answers? Anyone need a second chance? All right. Okay, so quite again, a reasonable spread, but actually maybe a bit more in the agree camp in this audience. That standardization is the death of autonomy. You know, we are artists with our reports, for example, poets in fact, and how dare anyone take that away from us? That that opportunity to express ourselves, right? And so what was interesting was that just at the time that we were doing one of these talks, there's a neuroradiologist from the States, very well published, very well regarded, and both of them actually, who had started who had some comments on Twitter about exactly the same issue. And I think he, Walid Brinjikji, was annoyed that someone who was a junior consultant, had basically told him how he should be reporting. And I think that's where this came from. So it's an issue everywhere, and it's a real thing. And so these are some of the really interesting discussions that we had with the rooms. And this is an aggregate of what the trainees said. So at the trainee level, it seems maybe more are towards, it's not necessarily the death of autonomy. Okay, so structured reporting was what I talked about. So what I did, I'll show you some of the slides that I used for this talk and talk about some of the things. And what I should say is that this is not meant to be promotion of structured reporting. This is not me preaching. It's just showing different aspects of it that I think we should think about, because I think often we think about it in very simplistic terms, and that doesn't help anyone. So another question for you, please. Oh, hang on a sec. Let me just. Yeah. So at the moment, how do you feel about structured reporting? Yeah, still an answer. Okay. Is that coming up? Oops. I've got some responses. Should be okay. Someone's really hedging there.
Somebody's way off the bottom of the scale.
Yes, yeah, really not happy. Fair enough. Fair enough. Okay, so one of my a lot of this is based or was inspired by this book, which is an excellent book. I recommend it. If you speak to Dave Bowden, he'll strongly recommend it to you as well. And that's where I got the tip from initially. And it's just a very thin book. You'll read it very quickly, but has some really good ideas and tips, quite practical ones about reporting and on the use of language and so on. So I highly recommend it. Well, what's funny is when you listen to a talk, including this one about structured reporting. This paper gets brought out almost every single time. And it's a paper by a radiologist who was head of American College of Radiology at some point, etc., Preston Hickey. And I suppose the thing to remember is that this paper was written less than 20 years after Röntgen actually discovered X-rays. And immediately, what he's talking about is he went to a conference on sarcomas and realized that all the reports of those bone tumors were so heterogeneous, you couldn't even understand what the bone tumor actually was from the description. And it also meant that they couldn't put that data together, make any useful inferences from it. And the clinicians, in fact, then dismissed the radiology report as not a very useful tool. So he decided, well, there needs to be some sort of structured reporting. And this is one of the ones that he had suggested in that paper. Dr. Granger, do you use this one at all? Yeah, I thought so. And so, this is very early days, and yet 100 years later, not everyone does this, right? And so that debate has been going on for a long time. And so I think one of the important things to remember is that actually structured reporting is not just a template with some headings and some text, but it relies on, first of all, on standardization, which is our theme anyway. So you need to have standardized words, an understanding of what, the descriptions of the pathologies and so on. And once you've done that, then that can lead to a kind of structured report, which is a more, the IT side of things, the format of this report. Is it readable? Is it usable, machine readable, for example? Okay, so what kind of things are we talking about with standardized reporting? And I had three sort of areas three aspects to look at. So the things we see, so for example, all the descriptions that we have of all the RADS systems, right? There's loads of them now, and they're very, very useful. I mean, it is very helpful to have thyroid nodules, for example, described in a very as standardized way as possible, or almost anything, prostate, liver, neck, etc. But other examples which are not as huge on the scale, but are very useful are things like something called the SIN score. You might have heard me talk about it before, which is for metastatic cord compression. And what this helps to answer is, does an oncologist need to refer to a neurosurgeon? So is it stable, unstable, or indeterminate? And this standardized scoring system helps you determine that. And it, again, quite handy. And similarly, you've got a standardized way, for example, of describing, how bad a metastatic cord compression actually is. Otherwise, you're just relying on these descriptions which are not very clear, and words like threatened cord compression, what does that actually mean? And then the other side of standardization is something like this. So I asked our audience, what would you call this? We know it's really severe white matter disease, but what words do you actually use in your reports? And the reason for that is, Joanna Wardlow is a professor in Edinburgh who does a lot of work in this area. She and her groups showed that when you look at the literature, it's very difficult to put anything together because these are all the words for vascular abnormalities in the brain. Right? So you could have two for every week that you're reporting and choose a different one every time if you wanted to. So it depends on your mood. It's a bit like all the words that the Inuit might have for snow, or this one was especially for Professor Gilbert, but she'll miss out on this one. But these are all the words we heard for snow in Aberdeen. So based on this sort of heterogeneity of terminology for white matter disease, vascular white matter disease, a group came up with very standardized terms. So you might see us use some of these, although to be honest, not all of them. So for example, white matter hyperintensities of presumed vascular origin. It is a mouthful, but it comes from this attempt at standardization. Okay, things like radlexes might be another example you'll be quite familiar with. Okay, so let me clear the responses. The other thing is you've got terms of describing pathology, but then of course you've got all these types of words that you use in your reports. This is a slightly longer exercise, so let's see how we get on. But what I'd like you to try and do is rank these according to the degree of sort of positive certainty that they imply. So what do you think is the one that says, yes, this is definitely such and such pathology, versus not sure? So which is the most likely, which words, if you use them, suggest that this is the most likely abnormality? So at first glance, it might seem, it should be pretty easy and everyone should be quite consistent. So I'll just wait a little bit till the first person kind of submits the result, and then we'll see how it looks. So for a couple of people have responded so far. I think diagnostic of is probably the most certain. Probably is a bit more certain than likely. What do you think of that? Unlikely, fair enough, at the bottom. Consistent with is less certain than diagnostic of. Yeah, maybe. Compatible with, less than consistent with. Suggestive of has just pipped suspicious for to the post, and it's a bit more likely than suspicious for. Yet suggestive of is more likely than possibly. Do you think that's right? Probably is more certain than likely, or so which word would you use in your report to convey your degree of certainty? And so what we're trying to do with this exercise, and there's many, many papers about it, is to show how different words imply different things to different people. So yes, exactly. Now someone's decided actually more people think probably is more important, more certain than likely. And so not only is there a big difference amongst radiologists, but also amongst referrers. So what referrers think you're trying to say when you use a certain word might be very different from what you think you're conveying. And so is this something that needs to be standardized? It's much more difficult. Do you put probabilities on this? But then we don't know the probabilities for many things anyway. So that was quite a fun conversation. And this is just an example of one of the studies that showed how variable the meaning of these words or for people were. So this is a scale of certainty, the people who scored them, and the range of scores that each of these terms got. So for example, only diagnostic of had quite a short range of, yes, this is fairly certain with low score, and only
still quite a range for diagnostic of.
But still quite a range, yeah. And if you look at suggestive of, suspicious of, likely, they're all equally all the way across the scale, from it doesn't mean much to me, or yes, this means it must be this pathology, right? So important for us to consider this language, which is why we had speak no evil here. Okay. And so, of course, what are the benefits of standardization as things like consistency, reproducibility? I think it maybe makes you more efficient, because if you use the same words over and over again, that's much easier than each time having to think up of a slightly different set of words. And you need it for structured reporting. But the problems with standardization itself is, as you saw, some of it is based on consensus. The research is quite heterogeneous anyway, so the literature, so it's quite difficult. Again, this is just quite a useful one for anyone looking at lumbar spines. Should be all of you really, which is standardized nomenclature for lumbar spines. But this is again just consensus definitions. And then structured reporting has a whole other set of issues. So we think often, I think, of structured reports as the types that we do at the moment, which is a title and a paragraph. So there's quite a useful scheme of levels of structure within a report, which is what this paper tried to show. And level 1 is no structure. Level 2 is you've got your basic headings, and then level 3 you're getting into subheadings within those headings. So an example of a level 1, level 2 really is the CT head structured report. Now notice, this is the kind of thing that I think would put me off. This is from the RAD reports site, so the RSNA driven website of structured reports. But here, you've got brain, ventricles, extracranial structures, and then impression, and then all this other stuff, which maybe they have to put in. And you can see how this would make a report quite difficult to read, because if you had things that were related to each other in the different sections, then that wouldn't really, you're being forced to separate them. And I can understand why this would not be really usable. But then you can go beyond those levels of structures and have very structured elements within those headings. So these need standardized terms to be able to work. And the ultimate level is what's called synoptic reporting, which is what pathologists have to do. They've been incentivized to do it. But if you look at the reports, you'll see a synoptic report, which has every detail in terms of size and different characteristics and so on, as these fixed sets of elements. I understand that they also then fill in the free text bit with their bit anyway. But that's the sort of thing that people think of as structured reports. And so I think something like this is more useful. So this is a disease-specific structured report. So we're not saying do the same structure for every MRI head, but this is for multiple sclerosis. So multiple sclerosis, the clinician needs to know these sets of features about these characteristics, and that's what our structured report is aiming at. And so this might make a lot more sense. And I think this is the kind of thing that I would would like to work towards. Okay, and the kind of things that you might imagine will help with structured reports, of course, is especially the machine readability of that data. And then you can have automatic critical alerts or recommend follow-ups. If it's got this in it, then it needs to be followed up in 3 months or 6 months, and so on. Of course, ultimately, lots of machine learning. And those structures give much better annotated data sets than free text ones, which need even more processing to actually work out, like natural language processing and so on. But there are some challenges, and I thought this is quite interesting, that your report is read by many, many more people, I think, than you might imagine. And so, for example, an oncology report will go not just to the referrer, but to the patient, their GP, a surgeon, perhaps at some point down the line, the pathologist, another radiologist, a palliative care team, maybe a medical legal team. So, registries, public health, everybody. And so that report, of course, is tailored probably to your referrer mostly. So how do we get it to fit with these others? So that's a big challenge. I think what would be really amazing is if you had a structured report or some machine readable report that could then be automatically translated for the right audience. So, for a layperson or for the oncologist, etc. And of course, the other big thing is change management when you're trying to implement a structured report, and we've all seen this. And so this is an example, of course, of pre-PACS viewing. And yet you will find radiologists who like to view their images in exactly the same way on PACS. So change management can be difficult. And it requires a lot of resource investment, time. And then this is acknowledge Dr. Bowding for providing this example. And he said he didn't mind me sharing it, but it's nobody here. It's an external report. One of the problems with structured reports is when things don't get, when you take your structure for granted and you forget to check it. And so I'll just read this out because I realize it doesn't show very well on that screen. But it's a liver scan, and it says, contrast scan of diagnostic quality, lesion shows washout. And then the next sentence, the lesion shows no washout. The feature shows features of a malignant/benign lesion, and then some other stuff. Then, luckily, there's an addendum. It picked up on it. The addendum says, please ignore. On the contrast scan, it's of diagnostic quality. The lesion shows washout. The lesion shows no washout. The contrast scanning shows features of a malignant / benign lesion. So exactly the same thing was just copied and pasted, and they forgot to change it. So you have to be careful of how you implement your structured reports. Very careful. But there's a huge amount of data. So Curtis Langlotz in his book says, it's like the oil of petroleum of radiology or of medicine. So probably where we are now is at the stage where we can develop structured report templates which are disease specific with those headers and things. But I think the synoptic reporting type of thing will come much, much later. And there are many, many reports where I wouldn't want to do that. But there are some, so for example, CT sinuses, for example, where I would love to do it so we can get through them much more quickly. So the future, there's a lot of promise with structured reporting in the future. Then everybody, I think many of you will have seen this cartoon already, perhaps. But one of the things that it's driving towards is machine learning. And then we'll see who's liable. Okay, so having said all that, how do you feel about structured reporting now? And let me just remove these responses. Do you think more towards green than it was before? It doesn't have to be. That wasn't necessarily the aim. It was just to see if it had brought any ideas to people's minds, any differences. Thank you. Okay. Oh, so I'm very happy. And so this was the amongst the sort of summary of what the trainees had said when we asked them. So this is before the talk, and then interestingly, this is after. So more kind of towards the middle, and maybe that shows that there's lots of issues, there's pros and cons, and that's I like to think that that's what we are trying to get across. Okay. So did we get any good feedback? Of course, I'm mostly going to show you the positive feedback. So that was a very nice nice tweet that we got. There's my the radiologist's toolbox right there. And so this was the sort of, we asked a few questions, and we asked them to between agree and disagree. And so green is strongly agree or agree. And so people generally enjoyed the presentations. They like the teaching. We're very happy that generally interest was maintained. But these were I think the more interesting questions. So has your interest in neuroradiology increased? And there were a reasonable number that said yes. There were a couple that said no, but that's okay. And then has your interest in research increased? And that's not as high as the other one. But then in the end, do you think what you've seen today will be useful for the future? And most people agreed. So overall, we're very happy with this feedback. And 97% would recommend a Deboulé session again to other training schemes. There's always a 3%. That's okay. And so these were some of the very nice comments that we got from the feedback. And it was quite interesting that they did find those other the general topics on structured reporting and standardization. So on reflection, I mean, this is a great experience, and I'd highly recommend it to anyone who might be thinking about it for the future. And it's really great to be able to visit all these places. We don't often visit other training schemes, so to see how they're managing, or maybe not managing. Backlogs are the same actually everywhere. The pressures are very similar. The pressures on teaching and education are very similar. But it was a really great privilege. So yeah, very much enjoyed it. And of course, acknowledge the people who are very important to make this happen. So Sam Mills, my joint professor, Dan Scoffings, who provided some of the material for one of the talks, my colleagues who were very patient and very kindly, covered when I was away at these places, and then the society. So I think it's a great scheme that the Royal College and the special interest groups are taking on, are running. And what's really good is that there's quite a lot of the special SIGs are doing these traveling professorships in many different subspecialties. So it just shows that it's very well very welcome and well regarded. So yeah, so that's all I had to say. I really enjoyed it. So let me know if you have any questions about it.
Excellent.